Okay, so in this month's issue of the Whitney Marsh Foundation newsletter, we are honored to feature Dr. Rangaswamy Govindarajan, or Dr. Govind for short. He's a distinguished professor and the division chief of the medical oncology and hematology department at UAMS, and he specializes in gastrointestinal cancers, including pancreatic cancer. Dr. Govind's work in the field of oncology and his dedication to advancing treatment options for pancreatic cancer have made him a leader in the fight against this disease. And in this interview, we'll delve into what pancreatic cancer looks like for patients, discuss its challenges, and explore the future of what care will look like for patients. So let's get into some questions. First, Dr. Govind, thank you so much for joining us today. To start, could you give our readers kind of an overview of what pancreatic cancer is and why it's so difficult to treat?
Pancreatic cancer uh, is cancer arising from the pancreas. There are two kinds of cancers. One is an exocrine and an endocrine pancreatic cancer. The endocrine pancreatic cancers are more indolent, meaning slow growing, whereas the exocrine pancreatic cancer starts in the pancreatic duct and he is more aggressive. And most of the pancreatic cancers of either endocrine or exocrine do not have early symptoms. So by the time they cause symptoms in patients, they're pretty advanced. That's why it's so difficult to treat.
Since pancreatic cancer is often diagnosed at later stages when patients become symptomatic, um, how has early detection evolved in recent years, and what can patients do on their part to catch it earlier?
Unfortunately, there is no standard uh, detection methods for pancreatic cancer. For example, for breast cancer, we have mammogram.
Right.
For colon cancer, we have colonoscopy. And lung cancer in high-risk individuals, we have low-dose CT scan. And for prostate cancer, you can check PSA and do a digital rectal examination. Unfortunately, there is no standard for pancreatic cancer in patients of average risk. However, there is intense research and also some guidelines for some patients uh, to have screening methods for early detection, especially in those who have family history of pancreatic cancer and also have some hereditary cancer syndromes. Otherwise, for average risk population, there is no screening method which is standardized.
And for those patients who do unfortunately develop pancreatic cancer, what are the most common treatment options for them currently? Um, and how do they vary depending on what the stage of the disease is?
Most of the patients present with advanced stage, and by the time they come with symptoms, when I mean advanced, in other cancers, staging is very important, like colon cancer and breast cancer and lung cancer, stages 1, 2, 3, and 4, where the guidelines are very clear for each stage. Unfortunately, for pancreatic cancer, it's not so straightforward because irrespective of the stage, the resectability for pancreatic cancer, that means to have surgery, there are different uh, criteria, such as involvement of blood vessels, which is one of the most important one, which determines whether the patient can have surgery or not. The treatment options are surgery for localized pancreatic cancer. Then if it's more advanced, there are conditions called borderline resectable, where on the initial evaluation, the surgeon feels that they cannot remove the tumor. So you need to give some chemotherapy with or without radiation and take for surgery. And it's more advanced, like unresectable. That means those who cannot have surgery. And those who have cancer which are spread to different organs, chemotherapy is the choice.
Okay. And for some patients, do they have the option to do chemotherapy prior to surgery or what's called neoadjuvant chemotherapy?
Yes.
Okay.
For patients who have what's called borderline resectable,
Mhm.
borderline meaning they are almost there to get surgery, but they do have some involvement of blood vessels. So the probability of having complete cure with surgery is very low. In those patients, the usual practice is to give them chemotherapy first and then repeat scans. And if the tumor has shrunk enough so that the surgeon can have clear margins without involving the blood vessels, or after chemotherapy, if the response is not adequate, we usually offer them radiation therapy and then go for surgery.
Okay. Can you do both a combination of chemotherapy and radiation prior to?
Yes, we normally when we give radiation, we give low dose chemotherapy to sensitize the tumor to radiation. That's the standard practice.
Okay. And since chemotherapy and radiation are the standard treatments, are there any new therapies or clinical trials that offer hope for patients?
Yes, for patients who have microsatellite unstable disease, which is seen in what's called Lynch syndrome or microsatellite unstable disease, which is pretty common in colorectal cancer and other cancers. But in pancreatic cancer, unfortunately, it's less up to 1% of patients have the microsatellite unstable disease. These patients can be treated with immunotherapy rather than chemotherapy and radiation. And
Okay.
also, there are other mutations for especially for hereditary pancreatic cancers, which is called PAL mutations and BRCA1 and 2 mutations. The BRCA1 and 2 is very common in breast and ovarian cancers, but is only found in about 2.5% of pancreatic cancers. Those patients can have what's called PARP inhibitors, which can be added to chemo, which can be used as maintenance therapy after chemotherapy.
Okay. Um, so with the immunotherapy, that's more for patients that have that genetic component or familial syndrome. Uh,
Mhm.
but whereas, the majority of patients, it's a spontaneous mutation, chemotherapy and radiation are better options.
I wouldn't say it's better options. That's the only available option, unless we come up with new treatment options in the future.
Right. And since pancreatic cancer does carry such a poor prognosis, what are some of the challenges that you think researchers face in finding more effective treatments?
Pancreatic cancer is not very chemosensitive or radiosensitive tumor, and the part of that is because the tumor has dense interstitial stroma, which prevents the chemotherapy and radiation therapy to penetrate the cancer cells to be very effective. That's one of the biggest challenges in treating pancreatic cancer.
And how important do you think it is to personalize medicine in the treatment of these patients with pancreatic cancer? Um, and you kind of touched a little bit on the role of genetic testing and how we can use that to tailor treatment plans. Can you kind of expand a little bit more on that?
Yes, nowadays it has become common practice to do what's called next generation sequencing of all patients who walk through the door in oncology clinic. With this approach, we are detecting more and more patients with mutations, which is called somatic mutations within the tumor, which can guide us for treatments such as microsatellite instability, PAL mutations, BRCA1 and 2 mutations, And also, we can stumble upon other mutations which can be targeted by certain drugs which were not tested for pancreatic cancer, but have been tested in other tumors. It's called tumor agnostic treatments. That means it's based on the mutation rather than the type of cancer, which is a new method of treating cancer patients, especially on clinical trials. That's where the current research is heading.
And are you or any of your colleagues currently working on any pancreatic cancer research?
Yes, at the Cancer Institute, we are still in the early stages of developing new treatment approaches. For the one of them is using some vaccines to inject into the pancreatic tumor to generate an immune response from the host.
And can you kind of tell me what the dynamic is with multidisciplinary teams? Because patients will have a team of providers like a medical oncologist and a surgeon if their tumor is resectable or can be resectable. Can you kind of explain what that looks like for a patient?
Yes, we have weekly tumor boards where we discuss these patients. All the patients with pancreatic cancer are discussed in the meeting where the medical oncologist, surgical oncologists, radiation oncologists, and the pathologists, we are all talking about the same patient. So each of us will give our opinion as to what is the best way to proceed for that particular patient. Because the options, as you know, or as we discussed, is surgery, chemotherapy, radiation in combination, in sequence, one way or the other.
And my last question for you is looking ahead, what do you think is the future of pancreatic cancer treatment? And what do you think in the next 5 or 10 years holds in terms of breakthroughs or improvements that could potentially occur?
Uh, I don't know what is in future, but the aim is to find other treatment options rather than try the same thing which hasn't worked, like chemotherapy and radiation. Surgery is still the mainstay of treatment, but, but what works with surgery, either pre in the neoadjuvant or adjuvant setting. Like 10 years ago, we did not know anything about immunotherapy, and now we do.
Right.
So probably there will be more targeted therapies, viral therapies. We don't know what's in future. Hopefully, with the current trend, there will be new breakthroughs. I don't know which one of them is going to succeed.
Okay. I think that concludes our interview. So on behalf of the Whitney Marsh Foundation, thank you so much, Dr. Govind, for sharing your expertise with us today. We appreciate your dedication so much to advancing pancreatic cancer research and treatment. And we're grateful for the opportunity to sit down with you and learn more about the future of care for pancreatic cancer patients.
Okay, thank you very much for interviewing me.